Welcome to the deep dive. Today we're tackling ANCA-Associated Vasculitis, or AAV.
That's right.
It can sound a bit daunting, I know, but think of this as your high-yield guide. We want to help you get a solid handle on it efficiently.
Exactly. We'll break down the essentials, focusing on what you really need to know about AAV.
Okay, so AAV. What is it, fundamentally? Well, we're talking about a group of autoimmune diseases.
Right. Autoimmune, so the body's immune system mistakenly attacks its own tissues.
And in this case, it's the small blood vessels. That attack leads to inflammation, maybe some damage.
And the key clue, often, is the presence of certain antibodies, antineutrophil cytoplasmic antibodies, ANCA.
ANCA, got it. And there are different types.
Yep, three main ones to be aware of: granulomatosis with polyangiitis, or GPA,
Okay.
microscopic polyangiitis, MPA, and eosinophilic granulomatosis with polyangiitis, EGPA.
Right. GPA, MPA, EGPA, different flavors of the same underlying issue.
Sort of, yeah. Different branches, maybe.
Okay. So we're going to explore this whole AAV picture to make it clear. Let's start maybe nailing down that definition a bit more. Autoimmune, small vessel inflammation.
Yes. And it's useful to know it's usually a primary vasculitis, meaning it's the main issue, not caused by something else,
Ah, okay.
as opposed to secondary.
Exactly. Secondary vasculitis might pop up because of, say, an infection or another condition like lupus or even some drugs or cancers.
So the vasculitis is a consequence in those cases?
Right. With AAV, it's typically the primary problem itself.
Okay. And how does AAV fit into the, the bigger classification of all the different vasculitis types?
Well, there are classification systems, like the Chapel Hill Consensus Conference, the CHCC. It helps organize things.
Like a directory?
Kind of, yeah. It groups vasculitis based on things like vessel size, large, medium, small, and key features, like whether ANCA is involved.
So AAV falls into...
Small vessel vasculitis, and it's specifically defined by that ANCA association. That consensus helps everyone globally use the same terms. Right, keeps everyone on the same page. Okay, so AAV, primary small vessel ANCA linked. But why does it happen? What actually causes it? The etiology?
Yeah, that's the million-dollar question, really, the precise cause. And, well, it's still not completely pinned down.
Oh, okay. Not just one single trigger, then.
Yeah, it seemed like it.
Yeah.
The current thinking is it's likely a combination. You probably need a certain genetic predisposition.
Right.
And then some kind of environmental trigger, maybe an infection, maybe something else. It's like your genes load the gun and the environment pulls the trigger.
Interesting analogy. So you need both factors to align.
That's the idea. We don't know all the exact triggers, but research points towards that kind of interplay.
And looking beyond just AAV at vasculitis generally, are there known causes?
Well, yes. While AE is often idiopathic unknown cause, other vasculitis forms can be triggered by infections. We sometimes see GPA flare up after an upper respiratory tract infection, for example.
Okay.
And some drugs are known culprits too, like certain antibiotics, sulfonamides, for instance, can cause drug-induced vasculitis.
Right. So thinking about AAV specifically, are there known risk factors, things that make someone more susceptible?
Well, the genetics we mentioned. Certain gene variations, like HLA-DPB1, seem to slightly increase risk.
Okay.
And then exposure to certain, still not fully defined environmental factors. And also, sometimes, a history of respiratory infection seems to be linked.
Okay, so genetics, environment, maybe past infections. Now let's get into the mechanics. What's actually happening inside the body, the pathophysiology?
Okay, so the central players are those ANCA antibodies we mentioned.
Right, antineutrophil.
Cytoplasmic antibodies, exactly. Now, neutrophils are a type of white blood cell, part of your immune defense.
Your infection fighters.
Your frontline fighters, yeah. But in AAV, these ANCAs mistakenly target proteins inside the neutrophils.
Okay, so they turn on their own cells.
Essentially, yes. This targeting activates the neutrophils. They then stick to the walls of small blood vessels and release damaging inflammatory substances.
Ah, so it's the activated neutrophils causing the vessel damage.
Precisely. It's like the immune system is causing collateral damage while trying to fight something that isn't really there, or misinterpreting signals.
And where does this damage typically happen? Which organs?
The kidneys and lungs are very commonly involved. The upper respiratory tract, 2 sinuses, nose.
Okay.
But because it affects small vessels, which are everywhere, it can theoretically affect almost any organ system. That's why symptoms can be so widespread.
Right, that makes sense. So with such varied symptoms, how do you differentiate AAV from other things? What's the differential diagnosis look like?
That's absolutely critical. You have to consider other types of vasculitis, maybe ones affecting larger vessels like giant cell arteritis, or medium vessels like polyarteritis nodosa.
Even if they affect different sized vessels?
Yeah, because some general symptoms like fever or fatigue can overlap. You also need to think about other autoimmune conditions.
Okay. So how do you narrow it down?
It's about putting all the pieces together. The patient's story, their specific symptoms, the lab results, especially that ANCA test,
Right.
imaging findings, and often the definitive answer comes from a tissue biopsy, looking at the affected tissue under a microscope.
The biopsy confirms the vasculitis in the vessel wall.
Exactly. It shows the inflammation directly.
And what about when it shows up on the skin? Can that be confusing?
Oh, definitely. Skin lesions in AAV can sometimes mimic other things, insect bites, simple bruising, even some pigmented spots, or conditions causing purpura, like low platelets or DIC. There's even a skin condition called pityriasis lichenoides that might look similar sometimes.
So lots to rule out. Okay, moving on. How common is AAV? What's the epidemiology?
In the UK, we're talking about maybe 20 to 30 new cases per million people each year.
Per million, so relatively uncommon.
Yes, it's considered a rare disease group. It can occur at any age, but it's most common in adults, often peaking between ages 50 and 70.
And compared to all vasculitis types?
Vasculitis overall is rare, maybe around 14,000 new cases of all types in the UK annually. And conditions like polymyalgia rheumatica or giant cell arteritis are actually much more common than AAV.
Okay, that puts it in perspective. So let's talk about what AAV actually looks like for a patient. The clinical features.
They can be really varied. Often there are general sort of constitutional symptoms, feeling really tired, losing weight without trying, maybe a persistent fever.
The systemic stuff?
Exactly. Then respiratory symptoms are very common. A cough that won't go away, shortness of breath, sometimes even coughing up blood, which is called hemoptysis.
Serious lung involvement.
Can be, yes. Kidney involvement is also classic. You might see blood or protein in the urine on tests, or rising creatinine levels in the blood indicating the kidneys aren't filtering properly.
Right.
Joint pain arthralgia is common too. Skin rashes, the vasculitic rash can occur, though maybe not always the first sign. And ear, nose, and throat symptoms like sinusitis or ear problems are definitely part of the picture for some types, especially GPA.
Wow, okay. It really can touch almost any system.
It can. So the key things to look out for often cluster around renal problems, respiratory issues, those general systemic symptoms, maybe a rash and ENT involvement. But remember, how it first shows up can differ a lot from person to person.
With that wide range, what investigations are key for diagnosis?
Well, blood tests are crucial, especially looking for those ANCA antibodies. That's often the first big clue.
Okay, the ANCA test.
Then imaging chest x-rays, maybe CT scans to see what's going on in the lungs or other organs.
To assess the extent of involvement.
Exactly. And often, as we said, a tissue biopsy is needed for that definitive confirmation.
Yeah.
Actually see the inflamed blood vessel.
So what would be the typical first-line tests if you suspect AAV?
You'd usually start with urinalysis, checking for blood, protein, basic bloods like urea and creatinine for kidney function, a full blood count, maybe CRP for inflammation.
Standard baseline stuff.
Pretty much. And definitely the ANCA test. A chest x-ray is usually in there too. You can maybe remember it like urine, bloods, renal, FBC, CRP, ANCA, chest x-ray, UBAC.
UBAC. Okay, that's helpful. And if those initial tests do suggest vasculitis, what comes next?
Then you tailor it. You might do more detailed bloods, check liver function, other inflammatory markers, look for secondary causes, so hepatitis tests, maybe cryoglobulins, complement levels, check rheumatoid factor.
Ruling things out, looking for related issues.
Right. And depending on the picture, maybe an echocardiogram for the heart, other autoimmune markers like ANAs, definitely a skin biopsy if there's a rash, perhaps more advanced imaging if needed. It becomes more specific to the patient's presentation.
Okay, so once you have the diagnosis, how is AAV managed?
Management really revolves around immunosuppression. You need to dampen down that overactive immune response.
Right, calm the attack.
Exactly. Glucocorticoids, like prednisolone, are often used first, quite high dose usually, to get the inflammation under control fast, like putting out the fire.
The initial blitz.
Yeah. Then, for longer-term control, drugs like cyclophosphamide or rituximab are key players. They work in different ways to suppress the immune system more sustainably. And alongside that, you need supportive care, managing blood pressure, protecting the kidneys, treating any specific organ damage. It really needs a multidisciplinary team approach.
Makes sense. Are there general principles for treating vasculitis overall?
Yeah, some common themes. Obviously, avoid triggers if you know them. Corticosteroids are almost always used for flares. Other immunosuppressants like azathioprine or methotrexate might be used in some vasculitis types, maybe less so as primary AAV treatment now, but sometimes for maintenance. Mycophenolate is another option, often used in AAV maintenance.
And for really tough cases.
For severe or resistant disease, you might consider things like plasma exchange, plasmapheresis to remove antibodies, or IV immunoglobulin, and newer biologic drugs are increasingly used too.
Does surgery ever play a role?
Usually medication is the mainstay, but yes, sometimes. If there's severe narrowing of a blood vessel, like in subglottic stenosis and GPA affecting the airway, you might need stenting or balloon dilation, or surgery for a biopsy, or to repair damage.
Okay. And how do you track progress? How do you monitor?
Regular follow-up is essential. Blood tests like ESR or CRP can track general inflammation. In some AAV types, like GPA, the level of ANCA might correlate with disease activity, though that's not always clear-cut. Plus, regular checks of organ function, kidney tests, lung function tests, perhaps.
Constant vigilance, basically. So what's the outlook? The prognosis for someone with AAV?
It really varies. Depends on the type of AAV, which organs are hit hardest, and importantly, how early it's diagnosed and treated.
So early diagnosis is key.
Hugely important. Outcomes are much, much better now than they were decades ago. But people can still experience relapses, where the disease flares up again, and it can become a chronic condition needing long-term management.
But it's shifted from being typically fatal.
Oh, absolutely. Before effective treatments, AAV was often fatal, sometimes quite quickly. Now, with early diagnosis and modern immunosuppression, it's generally manageable as a chronic disease.
That's a massive improvement.
It is. But we shouldn't understate the challenges. Patients can still face reduced life expectancy compared to the general population, risk of relapse, side effects from treatment, other health problems, and impact on quality of life. So, still room for improvement in treatments.
Understood. And finally, what about complications? What can go wrong down the line?
Again, depends on the organs involved. Kidney problems can progress to renal insufficiency or even failure. Damage to small vessels in fingers or toes could lead to gangrene. Lung involvement can cause pulmonary hemorrhage, which is bleeding.
Serious stuff.
Yes. You can also get complications like strokes if brain vessels are involved, blood clots, and that subglottic stenosis we mentioned in the airway.
So managing the disease actively helps prevent these.
That's the goal. Good control of the vasculitis and regular monitoring are the best ways to minimize the risk of these complications and treat them promptly if they arise.
Okay, well, that's covered a lot of ground. Hopefully, this deep dive has helped make ANCA-Associated vasculitis a bit clearer for you, hitting those high-yield points for understanding or perhaps revision.
Yeah, key takeaways: autoimmune, small vessel inflammation, the role of ANCA, the varied ways it can present, and the absolute importance of early diagnosis and proper management.
Definitely take a moment to review those core concepts in your mind. Think about how the pathophysiology links to the symptoms and the investigation strategy.
And maybe reflect on this. Given how differently AAV can show up, what do you think poses the biggest challenge to actually spotting it early? It really underlines the diagnostic puzzle it can sometimes be.
A great final thought. And for anyone looking for more resources, particularly for MSRA prep, do check out passthemsra.com and also freemsra.com. Lots of useful material there.
Definitely worth a look.
Thanks for joining us on the deep dive today. We'll catch you next time.